the next session we are really fortunate to have put together, and I will tell you a little bit why we put this one together, because it particularly draws attention to the importance of ENAS, who won't be able to join us. When we went out for abstracts, one of the submitted abstracts had come from work that was being done in West Bank. And when we realised as a team that ENAS was planning to join us from Ramallah, it didn't seem the right thing to bring somebody over for 5 minutes and 2 for questions. I think you'll all appreciate that it perhaps would make be a little bit more respectful to give them a little bit more space and time. So we wondered how to do that. And that was when we started to think about the research as advocacy and humanitarian emergencies, which is a very pertinent topic now. It's always a pertinent topic, but in particular at the moment. So she was very much the trigger for this panel. Obviously, we're very disappointed that she's not able to be here. We know that she very much wanted to be. And we thank Yasmin Iraqi, who is joining in her stead to do her presentation. So I don't know whether she's able to hear the recording, but if the recording's happening, just an appreciation. Thank you very much to ENAS for inspiring us. So I will let you know about our panel. The way this is going to work, similar to the other ones, we will have presentations back to back, and then we'll have Q&A. And we'll have 3 presentations, then 4 members on the panel. So I'll introduce those people to you just now. So we'll have, some of you will have met Ola Ibarra, who is a consultant in infectious diseases. She was taking part in the humanitarian workshop. Whilst being a consultant in infectious diseases, that's probably one of about 500 things I could say about her, but she has enormous amounts of experience, particularly in humanitarian settings, in different countries around the world, but very particularly focused on Syria. And she, again, vast experience, and many of you have heard her speak, and if you have, then you've had a great pleasure and get to hear from her again. The second presenter, as I say, was going to be Enas. Tina, I will tell you about Enas. She is a medical programme officer at Medical Aid for Palestine. She manages emergency and mental health projects across West Bank, and has done an awful lot of work in sort of design and implementation of various different projects. I will let Yasmin introduce herself when she presents Enas's slides, but I also want to introduce to you James Smith, who will be our third presenter. James is a lecturer in humanitarian policy and practice at UCL and Deputy Programme Director of the MSc by the same title. If any of you pay attention to the media, James will not be an unfamiliar face and has been doing an exceptional job of keeping the subject of Palestine in the news in one of the most effective ways I think I have seen in the past couple of years. So, as I say, won't be unfamiliar to many of you, and anyone who came to our GECCo event last year will have heard him speak there. And last but not least, I have to mention Juan. Juan won't present, but he's going to join the panel. Juan is an emergency medicine doctor who has experience in humanitarian settings, has worked in various different countries in a capacity both pre-hospitally and in-hospitally, and was pivotal in creating this connection between Medical Aid Palestinians and the work that was going to be presented at our event. And we first met when Juan was presenting work of a similar nature at a USEM conference. So you've got a treat in store for you. First presentation will pop up, and so we'll invite Ola to come up first.
That's great. So good afternoon, everyone, and very well done for staying till the end of the day. So thank you so much to Anissa and the GECCo team for inviting me to speak. Up until about half an hour ago, I was going to speak ad hoc, but then I decided to put some slides together. I'm going to try and be brief, and I might skip over some of the slides, but it might give you some things to think about. I wanted to approach this by just getting you to think about, over the course of what you've heard today, why you as trainees in ED, and I know many of you are in IMT and lots of other specialties, might want to do research. Who are you doing research for? Is research ever effective at changing policies, raising humanitarian voices, changing things really for people on the ground? Because I think that's what we want to do, and I think that's the question that was posed to us. Those of you that know me will know I'm probably on the cynical, realist side, and very sadly it's because I've had to engage in academic spaces and advocacy spaces in the context of Syria, but not just Syria, lots of other humanitarian crises. So I was involved in Greece for the refugee response, in the Ebola response, and then onwards. And I like to think my pessimism is probably realism, but I haven't lost hope, and I also haven't lost the other important part, which is When sometimes I go, I don't like writing academic papers, I need to submit something today, there's about 7 authors, I'm chasing them for their paperwork, it'll be published in a few months, will it change anything? Probably not. People don't read NEJM or The Lancet, they're more likely to read The Guardian, The Daily Mail or The Sun. And when I've published papers that are more commentaries around attacks on healthcare, they've been far, far better read than some of the proper academic work that we've done in these spheres. But I don't want you to be cynical because I'm very old now. You need to be optimistic and you need to keep me optimistic and continuing the work. I wanted to highlight 3 or 4 projects that may be of interest. So yes, you've heard, I'm a reluctant advocate. I'm also a reluctant academic. I define myself as a humanitarian, as an educator. I still like seeing patients, but I've had to be, again, pragmatic and realistic. My MSF work is phenomenal. I spend about 50% of my work doing that as infectious disease malaria advisor, and I still keep up my clinical work. I have to be realistic. I can't do more clinical work than I do at the moment, and I've had to cut back a little bit. And I hate to say this, and I hope I'm not offending any academics in the audience, I've taken up an academic fellowship because it gives me a bit of chill time so that I can do the other things that I like to do. This is one of the groups, and those of you that attended the workshop with Munzer will know that he chairs it now. So about 10 years ago, I was going back and forth to the Syria-Turkey border. I was also hanging out at LSHTM, which was far more pleasurable than hanging out at Imperial College and similar, and far more pleasurable than the clinical training I was doing at the time. I think I was probably an IMT around then, and those of you that are IMTs know how difficult it is. And I started to get engaged in this space, and this is thanks to proper academics, proper humanitarian academics who are very successful in their field. And they invited me to join something that they launched about 10 years ago now at the Royal Society of Medicine, which was focused on some research, but mainly research that focuses on humanitarian action or policy change or advocacy. I put this up and I won't go through in details, but one of the things I want to highlight here, some of the projects that we've taken up are very much around the healthcare workforce in Syria, something that's very forgotten. And I'm talking about Syria because that's my passion, but we can also talk about our Gazan healthcare worker colleagues, and we know hundreds, if not more, have been killed in the course of their work, many directly targeted. I could also say the same in Ukraine, in Ethiopia and Sudan, and all of us as healthcare workers should care, and all of us should question. And again, this is where my cynicism comes in, and I'm glad my colleagues are not cynical. They want to count the healthcare workers, they want to show people that health workers are being killed, whereas I'm sat there going, but we know Syria was one of the best documented conflicts in terms of attacks on healthcare anywhere. In Gaza, in real time, we're seeing the destruction. Actually, the destruction's over. The destruction of the healthcare system has occurred, and we've watched it for more than 20 months. Do we need more evidence to say the killing of 17,000 children isn't acceptable? And that's what makes me cynical. Do we need more research on this, or is it so obvious that the next step is people have to change? The reason I'm not cynical, and I continue to highlight this, and all of us are culpable because none of us, so the BMA have done some very good work, but the World Medical Association, which I guess is our international body, which I presume none of us engage with, I don't engage with them, they haven't put out any statements around attacks on healthcare workers and healthcare facilities, and this explains some of my cynicism. I'm going to speed up just a little bit to show you some of the other work that we've done. When I go, look, I don't like writing academic papers, it's really hard work, and sometimes I usually push back, but sometimes they try and get change. So the BMJ, who I respect a great deal, and I respect their editors, they used to try and get me to stop saying Russia and the Syrian government attack healthcare facilities. And obviously I push back and go, but they do. And they say, but you can't say that. And I'm saying, well, I'm not going to use the passive voice, and some of you that work on Gaza will know similar sorts of things with these academic journals. But when I stop, then I see what else is being published and some of the things that are being said around Syrian healthcare workers, and that means that we have to ramp up how we speak. And this is some of the work that we did. So R2HC, so Research for Health and Humanitarian Crises, is one of the most important funding streams. They've been heavily criticised, but they have done some really good work, and there's some really good outputs from them. They are struggling with the massive global financial crisis affecting global health, affecting humanitarian health, both in the practical sense, in the academic sense as well, which is a huge pity, because there is important space for exactly these sorts of academic pieces. This is a similar piece of work looking at the quantification of attacks on healthcare, not by the same funding stream. This is something that Maya and I did in our spare time with our colleagues from SAMS and King's College. But this is very stark, and this is something Syrians know. So Munzer sitting in the audience, I think you know this, but we've been able to put a quantification to it using data. And sometimes if people criticise me for saying, I don't know, I get criticised being told I'm not neutral enough or not political enough, but then I step back and go, but look, the data is speaking for itself. This is what happens and this is what we know. So the data is saying to us, before there's an escalation in conflict in a particular area, they start to attack healthcare facilities. So maybe this is where research can be helpful. I hope so. Sorry, I sound very old and cynical today. I wanted to show you the ugliness of attacks on health, and just to say this was in December, and those of us that sort of span academia and humanitarian, we continue to speak up, even when our voice feels small, and even when our voice doesn't feel impactful, and I think that's what you can all do. I've just put these up because I think they're important books to read, especially Len Rubinstein's book, which is one of the few books and best books on attacks on healthcare. And he's a world expert, and he's important because he's now an academic, but he comes from a legal background, and he was for many years with Physicians for Human Rights, who've done some brilliant work on Syria, and to a lesser extent in some of the other conflicts. I'd like them to do more, but they are suffering funding cuts, and they are suffering the inability to speak because, of course, they're situated in the US. So those of us not situated or whose jobs and our livelihoods are not at risk, we have a duty to speak up. In the interest of time, I'm going to skip that last slide, but that was relating to attacks on water and communicable diseases. But I put this here. In Syria, about 3 years ago, we started to see cholera. It's a surprise we didn't see cholera in Syria before that, but it's to do with the breakdown and actually the relentless attacks on water and water infrastructure, which we see. And it's continuing to affect Syrian communities now, and it's continuing to affect Syrian communities returning to their homes. So some of my family won't go back to their homes because there's no water infrastructure, there's no schools, and of course their homes are demolished, but even if they weren't, they've got nothing to go back to. I put this here because over the years, so some of you will have done the DTMNH, and I said to Dave Moore, gosh, I'm really sorry my talk was a bit political, but none of us should ever now, I'm embarrassed that I was ever apologetic for being too political. Not that I was ever particularly political, I just stated facts. And I just wanted to highlight this. So in our duty in academia, in our duty in advocacy, and in speaking up, we have to touch on the politics because it's so intertwined. So we must never be afraid to take something to any of the communicable diseases. I've not shown you the slide about the association with leishmaniasis and conflict, with cholera and conflict, many of the other communicable diseases, diphtheria and conflict, and I can go on and on. We must understand the political interplay for us to be able to clearly advocate. There were a lot of papers about cholera in Syria. For me, most of them fell flat because they were just like, oh, you know, there was a cholera outbreak because there was conflict. But actually, that only tells you half the story. The story here is about vaccine shortages and delays. This was about delays in humanitarian aid and inequitable distribution. So the politicization of aid, which we know starkly in Gaza, which we know starkly even in Sudan at the moment, and interrupted aid, and inability to access the places that we would like to do. So this is how I've come to, I didn't speak at all of these events, but I spoke at some of them. I spoke at an EU dialogue session last year on Syria, speaking about the healthcare workforce. Some of you, I hope, will recognise this remarkable lady down here. So the attacks on health work was presented in Istanbul at an OCHCR, so the UN sort of human rights body, with the brilliant Tlaneng Methacom, who's been a phenomenal voice on Palestine, among many other things relating to healthcare workers. So I've had to start to speak at some of these things. I'm allergic to many things. I'm allergic to politicians. I'm also allergic to WHO and UN bodies, but we have to engage with these audiences, and if we have credibility, and to an extent I've got credibility on Syria, we need to raise our voices and try and impact them and try and get them to listen, and some of them do listen, and there's some very, very good people in these institutions, and I'm going to make a wry comment, which is in MSF, many people worked with MSF for a long time, then you can get a really good job with the UN or the WHO if you do that, no longer as of the last 12 months, but before that you get a really good pension, you retire at the age, it's either 50 or 60, but whatever it is, super, super generous. And everyone knows with MSF you don't get paid very well. It's roughly half your NHS salary, if you're wondering. And so I just wanted to highlight this. I want to wind down, but I also wanted a lot of the debates on Gaza, trying to understand what we have learned on Syria, is can academic research be beneficial in the accountability stage? I'm cynical, but I'd like to hear other voices. In Syria, we have the IIM mechanism. From speaking to people at these mechanisms, there's some really important things. So for me as an average clinician gathering data, I don't have the right eye for what's needed legally to document what happens to patients, document what happens in attacks on health, for this to be held legally in a court of law. The other thing to bear in mind is in Syria, I think it's something like 60 terabytes of data. So this could take them years to go through. And we know the people in Syria who were responsible for the attacks on healthcare, the healthcare workers themselves who were responsible for torture in hospitals in Syria. So I'm from Homs, and opposite my family's home was the National Hospital. And we knew that the doctors there were torturing some of the people captured. The people captured hadn't done anything wrong. They're people like you or I who might have gone to protest for freedom and things like this. So we should be aiming for research, we should be aiming for advocacy, but on the same, we must be realistic in terms of what we write, will it ever hold up in court. The last thing I'll mention is the Lancet Commission on Conflict, Health and Forced Displacement. And I mention this because maybe there's something that gives me a little hope sometimes. We've had phenomenally heated discussions. There's about 30 commissioners. The brilliant Joanne Liu stood up and said, when people were trying to say, look, we need to be a bit nuanced on Gaza, we need to be a bit careful, we don't want to alienate people. She's the former head of MSF, and she was responsible for UN Security Council Resolution 2286, which is the one where, after the Kunduz bombing of the MSF health facility and the other attacks on healthcare, I think it was around 2016, she pushed for that. She made herself incredibly unpopular. She's a very brave lady who just was able to stand in front of the UNSC and say, this is unacceptable, these are the red lines that have been crossed so many times. And she was in one of these meetings and she said, no, we're not going to have a conversation about nuance. She said, the conversation is before Gaza and after Gaza. And I think those of you that know this will understand. 10 years ago, I would have said before Syria, after Syria, but obviously now we have many other conflicts, very sadly, and much destruction of healthcare. I won't speak much more about this, but do keep an eye out. We're hoping it will come out at the end of the year. Paul Spiegel is leading on this, and he's taken a 3-month sabbatical, and we're having a lot of dialogue behind the scenes, and hopefully more and more heated discussions, because we should all be very heated about conflict, health, and displacement. So I just wanted to share some of these insights, and I'll stop there.
Hi everyone. Sorry that Ines could not be here today. I'll do my very best to present her work. She wasn't able to come, I think it's important to highlight, because her visa was denied, which is a very poignant thing in access for people in this work coming from Palestine. So just a bit about me. I'm the Research and Policy Officer at Medical Aid for Palestinians in the UK office. Prior to coming to London 2 years ago, I've been working in Palestinian civil society in Palestine for about 2 years, for about 10 years. 2 years ago, 10 years. Yes, so this presentation is about a trauma scoping mission that Ines worked on in the office in Ramallah. Dr. Juan was also part of it, I believe, so he'll be able to answer some questions later on the panel. So the West Bank has been facing escalating violence and critical gaps in emergency trauma care for many, many years. This has definitely escalated ever since the escalation in Gaza in October 2023 and the parallel escalation in the West Bank as well. These trauma incidents often exceed the response capacity of existing Ministry of Health and emergency medical services systems. And so to address this, MAP initiated a trauma scoping mission in 2024 to identify these urgent needs and systemic gaps. So these are just some basic facts on the West Bank. Something important to highlight is that there are about 3 million Palestinians and there's around 5,640 square kilometers. There are different areas in the West Bank that are controlled by different factions. There's the Area A, Area B, and Area C, which I'll go to in a minute. There are over 450,000 Israeli settlers that occupy parts of the West Bank, with an additional 200,000 in East Jerusalem alone. So these Area A, B, and C are administered partly by the Palestinian Authority and Israel. You can see here the intense fragmentation, which is an Israeli policy to make sure that Palestinians in the West Bank do not have access to one another and access to essential services as well. So Area C is about 60%, which is administered by Israel. Something important to note is that as the days go by, more and more of the West Bank is becoming Area C, and almost everything is controlled by the Israeli security and Israeli army. So this is just a snapshot from the OCHA updates that we often see. Violence is escalating in the West Bank, not just from the Israeli military, but from the settlers as well, who are protected by the Israeli military as well. In April 2025, there were 16 Palestinian fatalities. Something that I noted this morning is until now there's about 100 more since April. Just from January 2024 to April 2025, there were 616 people killed, including 115 children. And the injuries are immense, and there are 904 children were injured as well. These are daily. Every morning we wake up and we see different numbers, and it's always been going up ever since 2 years ago in October 2023. Something also important to note is the displacement that is occurring in the West Bank as well. There is over 41,000 people that have been displaced. This is mainly in the north governance of the West Bank, particularly in Jenin and Tulkarem, which are home to refugee camps. Jenin and Tulkarem saw immense raids and violence from the Israeli military, especially in January of this year when Jenin was raided, and almost all 20,000 of the residents of Jenin refugee camp were displaced. Now people have begun to return, but many homes are no longer existing, roads have been completely upended, and there are about 16,000, I believe, that are currently internally displaced in the refugee camps. Attacks on healthcare in the West Bank are ongoing and intense and immense. There have been 142 attacks on healthcare across the West Bank just within this year. This includes healthcare workers that are injured and killed, 41 injured and 6 killed. The access and attacks on healthcare goes beyond just attacks on individuals. It's attacks on systems, attacks on buildings, attacks on ambulances, which you can see here. There have been over 900 movement obstacles that have been erected in the West Bank, and these are mostly have been done since May, when there was a huge escalation in the West Bank. In lieu with the ceasefire, the first ceasefire in Gaza, things escalated immensely in the West Bank. And what we call the Gazification of the West Bank, where you're seeing policies and different aspects that are implemented in Gaza now being implemented in the West Bank. These obstructions include gates, checkpoints, earth mounds, literal earth mounds that are blocking people off from the roads. And this is not taking into consideration the settlements and settlement outposts that are erected around different Palestinian villages and cities in the West Bank. So you can see here a couple of other obstructions. Something that I think is important to highlight in attacks on healthcare is attacks on ambulances and blocking access for ambulances. So let's say there is someone who's been shot in the middle of the street by an Israeli soldier. The Israeli military cars will effectively block ambulances from reaching the person who has been shot in the street, most oftentimes leading them to bleed out on the street. So this is also an aspect of the access to healthcare. So a bit about the project that Ines has done, which is an amazing project which I'm happy to present on her behalf. The objectives of the scoping mission were to map trauma care pathways from the point of injury to hospital care, to identify key bottlenecks and opportunities for intervention, and provide evidence-based recommendations for MAP and stakeholders in the West Bank. You can see here the methodology. It was an exploratory mission mapping key aspects of trauma care in the West Bank, identifying challenges, practices, and areas for further research or intervention. This was a qualitative study which explored the context, experiences, perceptions, and behaviors through stakeholder meetings and interviews with healthcare providers and victims. And this was a research conducted across various locations in the West Bank as well. So I've been told not to focus too much on the findings and go mostly into how can we implement this research. But you can just see here that there are many, many gaps. There's the financial constraints, access and mobility restrictions, which I spoke about briefly before, escalating violence, and attacks on healthcare workers and facilities. So noting that there are many gaps, there are many levels also of the gaps in the West Bank. You have policy-making gaps, there's a disjointed system, poor communication between facilities, regions, and stakeholders. This is also due part to the fragmentation, which I spoke about briefly before. And there are no shared protocols or chain of command during these emergencies. And of course, a severely underfunded system. And community-level gaps, which you can kind of read a little bit here, just in the interest of time. And outdated or missing clinical protocols, severe shortages of human resources and specialized staff, and lack of essential medical equipment for trauma care. Sorry, there are a lot of transitions. So what needs to change? You can see here that there needs to be a decentralized care. There need to be more trauma stabilization points and urgent care centers, train community responders in stop the bleed triage and basic trauma, develop evidence-based emergency protocols for all levels of trauma care, integrate psychosocial support across trauma responses, and advocacy, which is what we are speaking here today, holding the people who are committing this violence accountable. Restrictions on attacks on emergency healthcare must be ended. Otherwise, what's the point? We can't implement these programs if the people who are stopping the programs are able to continue to do so with full impunity. And of course, investing in the Palestinian healthcare system. So the final takeaway, that the trauma care in the West Bank requires system-level reform, local preparedness, integrated physical and mental health response, and protection of healthcare providers under international law. The last part is obviously pertains to advocacy for healthcare workers. And yes, so what have we done with this report? And by we, I mean Ines, because she is amazing with the work that she has done. So the protocol leadership, we have co-led the development of national emergency protocols for both hospital and pre-hospital trauma care. The protocol leadership has been endorsed by the Ministry of Health, and the next steps are to roll out these new protocols. Expanding pre-positioning network, increasing trauma preparedness by establishing 4 strategic warehouses in Ramallah, Nablus, and Tulkarm and Hebron, stocked with emergency supplies for rapid dispatch. There is also a plan to establish 4 level 2 TSPs in volatile areas with local staff on standby. These sites have been identified. And surge capacity support design trauma-focused medical missions to Ministry of Health hospitals to strengthen emergency surgical responses. And missions are currently paused, unfortunately, due to the security constraints. Hopefully these will lift, and so we can continue these projects. And advocacy and system engagement, ongoing engagement with the Ministry of Health, WHO, and humanitarian actors to ensure protection of emergency medical services, unblock access barriers, and align trauma efforts across the West Bank. Thank you very much.
Afternoon, folks. I'm going to keep this brief because I really want us to get into a bit of time for some discussion. These are all 3 of my favourite things, so I'm really super excited that this panel has been put together. Since Ola introduced herself, I'm going to do the same, and I'm going to begin by saying that I am proudly cynical, and proudly cynical, I think, is sadly, as Ola's pointed out, an evidence-based position. And I think, if I may, one of the challenges with the sort of pre-post-Gaza sort of distinction is that it perhaps runs the risk of allowing us to forget the long lineage here of across contexts, but also within Palestine specifically. And I know that obviously you know this because you've both been working so extensively on Syria, that the failures in Syria have allowed really what's happening now in Gaza and throughout Palestine, and in particular also in the West Bank. So I'm cynical. I'm not perhaps I'm a reluctant humanitarian. I'm perhaps now, and I was just talking to Cam about this, I think I'd probably say I'm anti-humanitarian, and I'm happy to perhaps elaborate a little bit further on that during the Q&A. Nevertheless, I want to talk about advocacy. Most of my career in the international humanitarian sector has actually been in advocacy. I'm trained as a doctor, and I still do occasional kind of A&E shifts, but I started work with MSF as a researcher, then worked in their kind of humanitarian affairs and advocacy departments, and that's the other side of MSF, in addition to its kind of medical and sort of clinical arm. I want to begin by talking a little bit about this notion of evidence-based advocacy, and indeed advocacy full stop. The reason we do advocacy might seem, I hope, is pretty obvious. It allows us to do an awful lot more than we can do in the individual patient encounter. So we often, as emergency physicians, we talk about the sort of revolving door kind of illustration of, you see the same patient over and over again, and we need to be thinking about the underlying determinants of health, the sort of the basic kind of bread and butter of public health. I think that's what draws a lot of people to global health, to public health, to spaces like this. Really allowing us to think more about what actually is going on here and what is generating the needs that manifest in terms of sort of medical sequelae. Evidence-based advocacy has sort of emerged alongside this pursuit of evidence-based lots of other things, so evidence-based medicine, evidence-based public health, and more recently, in the last 20 years or so, evidence-based humanitarianism. That has been also driven by the fixation, or the growing fixation from the 1990s onwards on sort of rights-based approaches and rights-based programming in humanitarian practice, which of course allows us to think a little bit more clearly about those who are duty bearers and those who are rights holders. What we see when we think about evidence-based advocacy in global health and humanitarianism specifically is this shift away from sort of moral claims, which I'm going to elaborate a little bit further in the next slide, towards quantitative and arguably, or supposedly rather, objective evidence, which, as has already been alluded to, we are led to believe is less dismissible than someone simply saying, I saw this or I experienced that. Alongside all of this, of course, we've had this kind of very kind of technical turn in the field of advocacy and the emergence of the supposed expert witness, which is, of course, how these big kind of advocacy departments that I've floated through came to exist in the first place. All of this is underpinned by this belief that numbers, quantification, and supposedly objective science can allow us to shift the needle when it comes to policy making, introducing different approaches and so on. And the assumption there, of course, is that policymakers are rational beings. They're not at all influenced by ideology or the influence of other sort of prominent lobbying groups. So there's a gap in our knowledge and our understanding. We fill that gap with research. People weigh up the evidence that's in front of them, and they make decisions that are in our collective best interest. Of course, anyone that's paying attention knows that that's not the way that politics plays out. At a push, we can think about this notion of bounded rationality, which is that human beings have very limited capacity to sort of weigh up all of the information in front of them, so they make the best decisions they can under difficult circumstances. And again, I think that's quite a generous sort of assessment. When we think about humanitarian advocacy, or using research and data and evidence to inform advocacy in humanitarian contexts, we generally think about one or more of these three things. So in the short term, if we think about it across sort of the temporal dimension, we're thinking about pushing for improved access, pushing for improved resourcing, and then over the longer term, trying to shine a light on the underlying determinants of what manifests downstream as sort of medical needs. So violence, exclusion, neglect, and so on. So advocacy based around upholding the humanitarian principles, ensuring protection of protected persons, and maintaining some degree of functionality within a humanitarian system that we know is very much in decline. I won't dwell too long on this, but I want to just mention this shift away from sort of moral indignation towards sort of technical approaches to advocacy. The sort of history of humanitarianism sketches out this move away from what MSF would describe as témoignage, or sort of perhaps a more chaotic témoignage towards a much more technical approach to speaking out. So the sort of professionalization of the industry. And we see that both in terms of medical caregiving, but also in advocacy as well. It's a fantastic paper written by Arjun Clare, who used to work for MSF, now works for the Red Cross. And he describes advocacy now conceived as a triumph of reason and rationality over emotions. So that's the transition that's taken place over the course of the last 30 years or so. Important that we think about, at the same time, the ways in which coloniality moves through advocacy, and of course moves through research in and as advocacy. And this was something that was discussed during Munz's workshop earlier today. So we need to think about, are we advocating on behalf of, or are we advocating as? This sort of distinction between the etic and the emic perspectives. Who's speaking, how, and with what relationship to those people who are directly affected. And again, there's been an awful lot written about coloniality in not only research processes, but in humanitarian advocacy and humanitarian communications and so on. I think this is my last slide, and I'm going to end just by reflecting a little bit here on researchers' advocacy in Palestine. A major bugbear of mine that I've discussed with Anissa, I've discussed with Aula, I'm sure I've discussed with other folks who are in the room here, what I perceive to be one of the biggest failures of the few humanitarian organizations that have the privilege of access to Gaza now. And some of you may challenge me on this and say this is an unfair accusation, but a failure to collect data that constitutes good quality, that can be used as good quality evidence in Gaza. There is only one emergency medical team thus far over the course of the last 21 months that has published in a public forum any data related to the patients that they have cared for during that period. All of this is, of course, complicated by the fact that routine data collecting sort of infrastructure has been systematically targeted and destroyed as part of the wider targeting of the healthcare system, anti-Palestinian racism, which has led to the widespread questioning of the lived experience of Palestinians, who of course are documenting in real time what is being done to them, and the widespread use of tactics of disinformation, which has been described as the so-called fog of war. There is some interesting research that has come out of Gaza thus far, and a lot of this is reactive. And I say reactive because, as you'll see over here, this culture and these processes and systems of disinformation have led to a lot of questioning. The questioning, of course, of mortality data. So Palestinians have been so dehumanized that even their death is now questioned, which has in turn driven a lot of the work to try and better understand the true scale of mortality. There's been some very good modelling research done by researchers based out of LSHTM and elsewhere that have used interesting capture-recapture methodologies to better model mortality in Gaza. A Gaza mortality survey that is available in preprint form, it hasn't yet gone through peer review, a survey that they were able to roll out despite the constraints in Gaza, all of which demonstrate that the Ministry of Health numbers are a significant underrepresentation of the total number of people that have been killed in Gaza. This I've just taken as a screenshot from a conversation I was having with a colleague not so long ago, where we were discussing exactly what I've just outlined, really. You know, this push for EMTs to collect more data. And they challenged me, that they're Palestinian themselves, they challenged me to sort of say, you know, there are limits to this kind of data and evidence conversation. How is it that we've ended up in a situation wherein the live-streamed genocide, as it's been called by Amnesty International, has been so brought into question that we need to be sort of chasing after numbers in order to demonstrate the full scale of what's actually happening. This is my final slide. So my takeaway points are that advocacy is central to healthcare practice. We need to be really thinking about our kind of core competencies as humanitarian health practitioners, and advocacy really is a very significant part of any good humanitarian practitioner's skill set. It's something that we are not trained to do well. Certainly doesn't form, to my understanding, any kind of key core element of clinical training programs. Important, nevertheless, for us to think about or ask, to be prompted to ask the question of, you know, do we always need to be doing more research? Is it a matter of a lack of evidence that's the kind of the stumbling block here? And this came up, I think, in one of the discussions during the workshop earlier. The problem isn't always that we don't have enough data. It's often, sadly, and this is where my cynicism comes to the fore, the data is there, it's that there's no political will to act. And finally, really important that we think about dissemination, uptake, and influencing strategies. A lot of researchers don't have a good working understanding of the way that policy-making processes work. How can we actually influence to maximal effect? You know, great to see the photos of Ara and others that have moved through these sort of policy-making spaces. We're often taught in a very theoretical way that there's, as I mentioned earlier, this kind of linear process of there's a knowledge gap, we fill the gap, people will act. It's obviously a lot more chaotic than that. And if I can just paraphrase the bear in the woods sort of phrase, you know, if researchers produce evidence but no one reads it, did they actually produce evidence? And this is something that I sort of bang on about all the time. And with that, I'm done.